Our next speaker is Dr. Ken Moise, who will speak on red cell alloimmunization in pregnancy, diagnosis, and management. Dr. Moise is really the expert in this area, and we're very fortunate to have him with us. He is a professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences, and professor of pediatric surgery at the University of Texas Medical School at Houston, and co-director of the Texas Fetal Center at Children's Memorial Hermann Hospital in Houston. Dr. Moise.
Thank you for having me today, and I appreciate the invitation by the Foundation for this chance to talk with you. My usual disclaimers, I have consulted with LabCorp, and I do author chapters on this particular topic for up-to-date. I have no off-label disclosures. We're going to talk today a little bit about the incidence of rhesus disease in pregnancy and why it still occurs. I'll talk to you a little bit about rhesus immune globulin, some of the changing ideas about how to use rhesus immune globulin, and then we'll talk about the tools we use today. In my 25 years being interested in this disease, we've seen some marked changes in how we deal with this disease. So a couple of questions first, right up front, see if you can get some of these right. This is the first question. So which of the following antibodies is the second most leading cause of hemolytic disease of the fetus and newborn? So A would be KEL, B would be D, C would be C disease, and D would be Duffy. Sounds like Who Wants to Be a Millionaire on that one. Okay, and then we'll move to the next question, which will have some implications for prenatal diagnosis. So what is thought to be the source of free fetal DNA in the maternal circulation? A, fetal squames, B, placental trophoblasts, C, fetal nucleated red cells, or D, fetal white blood cells? Okay. So move back to our slides, please. So let's talk about the various antibodies that are found in pregnancy. This is a large series from a Dutch group and looked at the various antibodies found. And what you see is that D is still very commonly found in pregnancy as an antibody associated with hemolytic disease of the fetus and newborn. E is next, and then KEL, but E is a naturally occurring antibody, and with the new gel technology, many blood banks are finding E's. This confuses the obstetricians. These E titers are very low, 1 to 1, 1 to 2, and usually of no clinical significance whatsoever. A little C we forget is an Rh antibody, but is associated with severe hemolytic disease. So if I had to pick the three big antibodies to remember for fetal disease, where we're going to treat in utero, it's D, KEL, and little c. And this is what's happened to rhesus disease over time. We can thank these two individuals, Frida and Gorman. Frida was the obstetrician in the group, and Gorman was a blood banker. And interestingly enough, they were both residents at the time in training when they came up with the idea of rhesus immune globulin. And based on their studies in 1968, what we know as the first product of rhesus immune globulin was approved by the FDA, and you begin to see a fall in the incidence of rhesus disease. In 1981, the American College of OBGYN recommended it be given antenatally in addition to postpartum. A further fall, in 1990, the Centers for Disease Control actually stopped asking for reports on the standardized birth certificate, although we still see diseases. And when you look at why we transfuse babies in utero, again, fetal disease, again, you see D at the top of the list. This is a large series from the Leiden group in the Netherlands. D is at the top of the group. KEL's number 2. So KEL's the next most common antibody that causes disease. Little c is up there. And then these are a smattering of cases in a very large series from a single referral center for the whole country in Holland of E, little e, and FYA. So again, D, KEL, little c are the players. And why do we even why are we still having this conversation about rhesus disease? Still, about 66% of patients that occur are due to antenatal sensitization. and 13% is we forget to give it. Believe it or not, even in our healthcare system, patients go without getting their rhesus immune globulin. Well, part of the problem is we always think about delivery, which is probably the most frequent time that a woman gets alloimmunized, but there are a whole list of other indications. And one of my favorites to preach about is when a woman comes into an emergency room during an automobile accident and she's Rh negative, we forget that blunt trauma to the abdomen, an airbag being deployed, can result in a fetal maternal hemorrhage, particularly if the placenta is anterior on the uterine wall, and rhesus immune globulin is indicated. And I've had multiple patients immunized this way. So any antenatal hemorrhage, any early pregnancy event is worthy of consideration of giving rhesus immune globulin. The standard in the U.S., at least, based on the American College of OB/GYN, is to get an antibody screen at the first prenatal visit in all patients, not just Rh negative patients, but if they're Rh negative at 28 weeks, repeating their antibody screen, and then giving them a standardized dose of rhesus immune globulin, and then at delivery they get a second dose. So 2 doses, one at 28 weeks to prevent antenatal sensitization, and then one at delivery. And those 2 regimens, those 2 doses are about 99% effective in preventing disease. The problem with failures usually results in not giving enough at delivery. And so 1 vial, if you would, will cover about a 30 cc fetal bleed, but in a small number of pregnancies, the bleed is greater than 30 cc's, and so additional vials are needed. And now both the American College of OB/GYN and the American Association of Blood Banks have gotten together and said that all pregnant women who are Rh negative should be screened for excessive bleeds at the time of delivery. And based on that screening, they may need additional vials of rhesus immune globulin. And so most laboratories, most blood banks in the country do a Rosette test. If it comes back negative, they advise that 1 dose be given. If it's positive, they go on and do a fetal cell stain. Most laboratories continue to do the Klaher-Becky stain, which is very difficult to do. Some do flow cytometry. I think only like 3% of blood banks in the country do flow cytometry for this. And it's interesting when you look at the blood bank guidelines on how to figure out the dose of rhesus immune globulin. They take the percent of fetal cells, multiply it by a factor of 50, which is equivalent to a maternal blood volume of 5 liters. We don't actually measure the maternal blood volume, and that gives us a volume of the bleed. They divide by 30, since 1 vial will neutralize a 30 cc bleed, round up to the nearest decimal, and add 1 to grow on, which I always think is interesting. And the obstetricians are then told give 3 vials or 2 vials, whatever's indicated. These are the products out available. Most people know the original product, but there are multiple products out on the market. The interesting thing to know, because we just had a case like this with 180 cc bleed calculated from an abruption, is that giving that many vials of intramuscular injections would take quite a while. And so we were able to use one of the intravenous preparations and give the entire dose over about 8 hours. And so the intravenous preparations that are new in the market can be used to neutralize a large bleed. And even for blood bankers, if you happen to give the patient an Rh positive unit of blood by mistake, you can neutralize that with intravenous rhesus immune globulin in the Rh negative patient. Much better than giving an IM. So the interesting part of this story from the Sing Sing prison experiments from Frieda and Gorman is that they gave the prisoners who were their volunteers, not sure we fly with the IRB today, they gave the red cells to the prisoners on Friday, and they were due to come back on Saturday to give the rhesus immune globulin, but the warden would not let them due to visitation. So they came back on Monday and gave rhesus immune globulin, and therein lies the science behind the 72 hours that's quoted to this day for giving rhesus immune globulin. So we don't know what the right window is. There's actually data to suggest it works sometime later. It's not a simple coating of the antigenic sites. There's not enough antibody to do that. It's probably a selective immune downregulation is the latest proposed mechanism for that. But obviously, once the patient's sensitized, it does not work. There are some controversies about other situations to give it. One of the controversies that still exists is, do you repeat the titer at 28 weeks? Our college, the American College of OB/GYN, leaves it to the discretion of the obstetrician. I've always advocated that we repeat the titer at 28 weeks. It seems like a simple test to do. And occasionally between the first prenatal visit and 28 weeks, a patient will become sensitized. Once you give rhesus immune globulin, the titer becomes positive at a low level, 1 to 2, 1 to 4, and so things get confusing. So you'd like to have a baseline repeat screen before you give the rhesus immune globulin at 28 weeks. So I'm in favor of doing that. Paternity, I don't give it to patients who say, Dad's here, he's got a blood bank card that says he's Rh negative. I don't give it. I do give it after tubal ligation. We see more and more couples who end up divorced, have IVF, and conceive through IVF, even though the tubal ligation has been done, and so you don't want that patient sensitized. And some people advocate giving it after 40 weeks. Most people don't give a second injection in a term pregnancy. So let's talk a little bit about the sensitized patient and what happens in blood banks. Hopefully, I will show you in a minute that maternal titer for the obstetrician is a screening assay. It's not a science. I didn't really realize this in my training until I helped with this 1994 CAP survey where I gave a tube of blood to a blood banker who asked for my help. In this tube of blood, or this sample was sent to over 1,500 blood banks in North America as part of this 1994 CAP Quality Assurance Survey, and everybody got the NTD right, but the titers came back between 2 and 2,048. Made me feel very warm and fuzzy as an obstetrician to know that that's how blood bankers do their titers. About 60% of the labs got it between 32 and 64 for the value, and about 86% between 16 and 128. But what it taught me, and what I've learned through the years, is that titers are not that reproducible between laboratories. And even in the same laboratory, our lab freezes sera and runs it in tandem with a subsequent titer. So we can compare results, because we see wide ranges, particularly at commercial laboratories, with very high titers. And as you know, people are using gel titers, which most obstetricians don't know about, will raise or give you a higher value of 1 or 2 dilutions than a tube titer. We still look at tube titers to decide on clinical management. We don't have any data on gel titers. So when a patient is referred to me who's sensitized, we do tube titers at our blood bank, and we define a critical titer as a titer at which the fetus is at risk for hydrops. It varies again with institution and methodology and the type of antibody. Most centers will use a threshold of 32 for anti-D. We use a lower threshold of 8 for KEL for a critical titer. We know that KEL attacks the fetus differently than D. It seems to suppress the bone marrow in addition to causing sequestration of red cells. So that's why we use a lower titer for KEL. So the thing that's changed the most for me in the course of these 25 years is the use of DNA techniques to determine whether the fetus is at risk. It was interesting trying to find this data because it's not easily published. I have to look at multiple sources. But if you look at various ethnicities, you can see the Rh positive rates of Caucasians, African Americans, Hispanics, and Asians. And then if you look at zygosities, you can see that being heterozygous, with the exception of Asian ethnicity, is quite common. And obviously, if someone is heterozygous, if the partner is heterozygous, you have a 50-50 chance of an affected offspring. In the past, we used to use serology to determine statistically whether a partner was heterozygous or homozygous. A lot of people still do that, but there are DNA techniques out. I'll demonstrate this one, where we can use the RHD exon of 5 and 7 with quantitative PCR, and also look at a control RHCE exon and compare peaks. So that's a negative. That panel shows a negative individual with only a peak in RHCE exon 7. And then on the next horizontal panel, we see a heterozygous individual. So there are peaks found in the D gene exon 5 and 7, but they're about half as tall on quantitative PCR as the internal RHCE exon 7. So that's a heterozygote, one copy of the Rh gene. And then finally, in the next panel, we'll see a homozygous individual, and the peaks are equivalent to the control RHCE gene, and therefore that's a homozygous individual. So DNA techniques are now available to specifically tell if someone is a heterozygote or homozygote. We no longer need to use serology to guess at whether someone is heterozygous or homozygous. There's always the issue of paternity in any of these discussions with my patients. I usually excuse dad from the room and sit down and talk with mom and explain that this is very important. If dad is negative and paternity is assured, then really we don't have a fetus at risk despite the maternal antibodies. If dad's positive and he's homozygous, we know the fetus is affected and we can move forward. If dad's heterozygous, we're going to offer some type of testing for the fetus. Today, we're doing free fetal DNA, which I'll talk with you about in a second. It's only available in the United States for D. The other antigens like Kel and C and Duffy have to be done by amniocentesis still. So DNA is obtained by amnio to do that typing. So free DNA has hit our market, and mostly for Down syndrome screening, but the first free DNA testing was done in D by Professor Lowe in Oxford. We now know it comes from placental apoptosis, so the placenta sheds DNA into the maternal system. We're not sure why it's there, but it clearly is present. As much as 3% of the free DNA pool of a pregnant woman is fetal in the first trimester and up to 6% by the third trimester. And the reason we know it comes from the placenta is it clears very rapidly after birth. In the past, we used to look for nucleated fetal red cells. We were concerned in years past that they would persist between pregnancies and cause problems for prenatal diagnosis, but free DNA doesn't have that problem because if you look at the half-life after the placenta is removed, it's very short after C-section and vaginal delivery, so it doesn't hang around till the next pregnancy. So it has really become the type of material to use for prenatal diagnosis when we talk about using maternal blood. So obviously you have a blood sample, and when you spin it down, you have a buffy coat of maternal white cells. That's going to be indicative of maternal DNA. You're going to have plasma that's going to have free fetal and maternal DNA in it. So this is a mixed sample above. And the problem is that if you have an Rh positive result, that's easy. You shouldn't have Rh positive DNA in the maternal bloodstream unless it's coming from the fetus. Remember, it can't be left over from a previous fetus. But when you have an Rh negative result, the question is that the fetus? Are you reflecting the fetal DNA, or did you just not amplify the DNA? Is there not any fetal DNA in the sample? And so there's only one assay commercially available in the United States, and they have addressed this issue by using some identifiers to be sure that you have fetal DNA in the sample. They use male identifiers and these SNPs. So an Rh positive male result, that would be valid because you have male DNA in the system. That has to be fetal. An Rh negative male result, again, valid because you have male DNA. An Rh positive female, valid because, again, you shouldn't have Rh positive DNA in the mother's bloodstream unless it comes from the fetus. But herein lies the problem, and that's the Rh negative female fetus. Is that a female fetus that's Rh negative, or are you just reflecting maternal DNA? And so the way the assay works, again, a positive result, that's valid on the free DNA testing. This is just a tube of blood taken from the mother as early as 10 to 12 weeks to determine the baby's blood type. If it's a negative result, we do reflex testing and look for the SRY gene. If it's a male, that's valid. If it's a female fetus, we don't know. We may not be amplifying fetal DNA, so we'll do reflex testing with these SNPs. The SNPs are compared between the buffy coat and the total DNA sample in the serum, and if there's more than 6 different between the buffy coat and the sera, then we know we have a difference that's related to paternal inherited SNPs, so that has to be fetal DNA in the sample, and therefore if there's a difference of at least 6 SNPs between the buffy coat analysis and the total serum analysis, then we have a valid result. So it's a little more complex than just getting a yes or no answer. There are these internal controls to be sure that free fetal DNA is being amplified. This is a study we did looking at the sensitivity and specificity of the assay at 3 different times in gestation in 120 patients, and you can see it's quite accurate. There are errors, there are false positives and false negatives, usually due to gene rearrangements, but the bottom line is this is a fairly accurate assay to determine the fetal blood type. So today, if we have a sensitized patient with a heterozygous dad, free fetal DNA for Rh, that's the only one we can do, is state-of-the-art to determine if that pregnancy is at risk. And if we do the assay and it's done appropriately and the baby's Rh negative, we know the fetus is not at risk. So let's say we have an anemic we have a fetus at risk. Either dad's homozygous for D, or dad, you've done free fetal DNA because dad was heterozygous and it came back for the D positive fetus. What do we do? So in the past, This is Frida again doing an amniocentesis many years ago to check for bilirubin in the amniotic fluid. That's an indirect marker of fetal hemolysis. So we would do serial amniocentesis to do delta OD 450. This is Liley's curve. This is Liley himself, and he created this curve. And basically there were 3 zones. If you had a value that returned in zone 1, that was mild disease, and zone 3 was a chance for intrauterine death. This is the OD 450 on this axis and gestational age on this axis. And I show this for historical reasons because it's very difficult to even find a lab that will do an OD 450 anymore. And the reason that's true is because in around the year 2000, a gentleman I was working with in Houston decided to see if he could find a non-invasive way of detecting fetal anemia. And he looked at a variety of blood vessels throughout the fetus and determined that the fetal middle cerebral artery was probably the best vessel to incinate to see if he could determine if the fetus was in fact anemic. And what he found out is if he could get end on with the vessel, this is the circle of Willis with color Doppler, this is the middle cerebral artery, that's the Doppler window, he could measure the speed, the peak systolic velocity of that vessel. And from some animal work, he determined that the faster the blood moved, the lower the viscosity, and in fact, the more anemic the fetus. And in a subsequent paper published in 2000 in New England Journal of Medicine, he determined that if the velocity was more than 1.5 times the multiples of the median, so that corrects for gestational age, that he had a sensitivity of 100% with a false positive rate of 12% of detecting an anemic fetus. And this changed the whole world of perinatology from serial amnios to using Doppler studies to determine the anemic fetus. This was a subsequent study, a multi-center trial that followed up Maury's study that looked at severely anemic fetuses, and they actually compared the Doppler study, the middle cerebral artery, to the OD 450 Queening curve and the OD 450 Liley curve, and across the board it worked better than doing amniocentesis and doing delta OD 450s. So as a result of that, I wrote this editorial, the New England Journal, that said, I think it's time to put the needles away, and in fact, that was published in 2006. Since that time, we no longer do serial amniocentesis in these pregnancies to determine if the fetus is sick. Here would be a typical case. This is the middle cerebral artery velocity on this axis, gestational age on this axis. Here's that action line of 1.5 multiples of the median. Here you see us doing Dopplers every few weeks and not putting any needle in the fetus. And then here at about 29 weeks, we notice the value increases and goes over that threshold line, and we do a blood sampling of the fetus, and it's found to be anemic. So in the year 2013, we're simply doing ultrasound now in a serial fashion to figure out when that baby needs therapy. So let's pull all these tools together and see what we do today. So if we have a new onset rhesus disease in a patient, we're going to follow maternal titers every 2 to 4 weeks. Again, we like to run them in tandem with previous titers, and until we reach that critical value, we're not too concerned about them. Again, we use a threshold value of 32. We're going to get dad's genotype done, his blood type and genotype in the meantime to see if this fetus is at risk. If dad's heterozygous, which would be about half of Caucasian couples, we're going to offer free fetal DNA testing for Rh. If it's a Kel case or a little C case, we're going to have to do an amniocentesis to get DNA from the fetus. We don't have free DNA for those antigens, but we can use an amniocentesis to determine the blood type. If dad's homozygous or we have an affected fetus by DNA testing, we're going to start Dopplers at about 18 weeks gestation. We're going to follow those Dopplers every few weeks, usually 1 to 2 weeks. If we get a value over 1.5 times the multiples of the median for gestational age, we're going to test the fetus by actually doing a cordocentesis, where we take blood from the umbilical cord, and if the blood counts below 30, we're going to give the baby blood, which I'll show you in a moment. And if we get up to 38 weeks and everything's looking good, we're just going to induce the pregnancy. If the patient's had a previously affected baby, we're going to probably be a little more aggressive. We're not going to worry about titer as much because it doesn't help us past the first pregnancy, and we're simply going to go straight to testing, and we're going to do Dopplers again starting at about 18 weeks and do them every couple of weeks looking for a change in titer. Now, how do we treat the fetus? Things have changed quite a bit in this area too. Back in the 80s, we realized we could put a needle into the umbilical cord fairly safely with ultrasound guidance. Ultrasound technology got better. It's about a 1% loss rate per procedure. This is what the room looks like. I think the most important part for us is we have a coulter outside of the room where we can determine the hematocrit very rapidly. There's usually quite a few people around the table, and they push me down to the end of the table just to supervise, typically. So let's see if this will play. I'll set this up for you. This is the skin up above. This is the placenta. We're actually going through the placenta with the needle here. And we're going to direct the needle on the ultrasound guidance directly into the umbilical vein. So we puncture the umbilical vein, and we draw a sample of blood, and we immediately can, within a minute or two from the coulter, determine the hematocrit. We provide a medication into the cord. We give a narcotic and a paralytic agent so the fetus doesn't help us with the procedure. And then we begin to infuse blood. During the procedure, you can see the blood moving down the cord. This is hematocrit of about 79% blood. To decrease the amount of volume we have to give to the fetus. And we have formulas we use to determine how much blood to give based on the fetal weight and the starting hematocrit, so we know we want to target a hematocrit of about 40 to 45 when we finish. And this is what we would do today. In fact, I just did one yesterday on a patient just before I got on the plane here. So the last time, we've gotten pretty good at these. So the last time we would do these would be at 35 weeks gestation. We've talked with a neonatologist. They'd rather us keep doing these and giving them a mature baby. We give mom phenobarbital. It's an old trick to help the fetal liver conjugate bilirubin when it comes out. We deliver that patient about 3 weeks after the last transfusion. Typically, we can induce that patient. And today, I have not seen an exchange transfusion in our nursery in the last 10 years using this protocol. So these babies stay with the mom for 2 days, and then they go home. But they're not done yet, and that's one of the biggest things and messages I will leave you with today. We do a pretty good job. This is, again, a big series from the Leiden group, again, in the Netherlands, of almost 1,500 transfusions, 91% survival, so that's pretty good. If the baby's hydropic, it's lower, but without hydrops, which is the way the patient should get referred to us, 95% survival with experienced people. This is the take-home message. We're not done. This baby has a suppressed bone marrow. When it's born, it's all donor cells. So that baby will come out with a blood type O negative with a DAT negative. And that baby will need to be followed fairly carefully. So we work with our pediatric hematologist to see that baby every week, to check a retic count and hematocrit. And usually that baby, about half the time, will need a top-up transfusion at about a month of age. Some of our babies have needed 3 transfusions before they start reticking and returning back to their own blood group. I think a lot of that's related to the fact that we don't do exchanges anymore, so we don't remove the maternal antibody from the neonatal system. And so the first little retic that comes out is taken out by the maternal antibody that still resides in the neonate. But the bottom line is these children have to be followed pretty carefully. There is now some good data on neurologic outcome. We've gotten better at transfusion, and one of our concerns was that we were saving sicker babies that might have neurologic deficits. This is again from the Netherlands group of 291 children that they transfused with a median follow-up of 8.2 years. And what they found is that the overall neurologic impairment was about 5%. So we've got 95% survival and 95% of those babies being normal. The rate of CP was a little bit higher at 2% compared to the Dutch baseline. And there was some developmental delay and, interestingly, some bilateral deafness that's thought to be related to high bilirubin levels in utero. So they do have some neurologic impairment, but it's a fairly low rate given as sick as these babies can be in utero. We've seen very hydropic fetuses with hematocrits of 5 and 6% who now survive with this intrauterine transfusion technique. So let's go back to our questions, and you should get these right easily now. We'll do our first question again. Which of the following antibodies is the second most common cause of hemolytic disease of the fetus and newborn? We'll see if you can push your buzzer. So Kell, D, C, or Duffy? Yeah, so everybody, I think we'll see the next slide. I think everybody got that right. It's Kell. Again, Kell disease is a very bad disease. Just so you know that most Kell disease we run into in this country is related to postpartum transfusions. As you know, you don't cross-match blood for Kell for our postpartum women. You cross-match for ABO and RH. 92% of the time they get a Cal negative unit, but 8-9% of the time they get a Cal positive unit. Luckily for them, most of the time their partners are Cal negative, but occasionally they are not. And so most of the Cal alloimmunization in this country is related to the use of uncross-matched Cal blood in women of reproductive age. That is not the case in Australia and some other countries. So you did better, and you got it right with Cal being the next most common. Next question, what's thought to be the source of free fetal DNA in the maternal circulation? Fetal squames, placental trophoblast, fetal nucleated red cells, or fetal white blood cells? Right, so it's placental trophoblasts. Remember, these go away very quickly. It's DNA. It's these trophoblasts break down through apoptosis. There are fetal nucleated red cells in the system. They don't seem to be contributing. They're intact, and they don't feel to be the major source of the free DNA in the system. And so you did better on that one. That's good. And one more slide, I think, for me. So I'm going to pull it back. So I'll finish with a story, and my story is the following. I took care of a patient. No, don't put it up yet. You mess up my last thing. Leave it right there. So the patient I took care of was a lady from South Texas, and she came to see me for 2 fetuses. I transfused 2 fetuses, which is the most I've ever done. No one's come to me 3 times. After 2 sets of transfusions, that's enough. And Kristen was 18 years old at the time when I took care of her second pregnancy, second fetus. Both fetuses had been hydropic. Both fetuses had multiple transfusions and did well. At 18 years of age, Kristen was in the middle of a divorce and wanted her tubes tied. She said, I have this terrible disease. You've saved 2 of my babies, and I really would rather not have any more children. And I said, well, I really can't do that. You're 18, and you have your whole life in front of you, but I will do this for you, so I'll give you this card. I want you to take it with you the rest of your life. I never heard back from Kristen, so I'm assuming it all worked out. Thank you so much for having me today. I think I have about 5 minutes for questions that I can take.
Hi, I'm an adult hematologist, so I use Winrow, especially in ITP.
Right.
And just about 2 or 3 years ago, I didn't ask the question yet, but the black box warnings have all of a sudden popped up for these anti-D immunoglobulin preparations. We know there's a potential for hemolysis. Is one preparation safer than another? And I noticed the new recommendation is to give an antepartum dose as well as a postpartum dose, and is that a problem?
Well, again, my patients, unlike your patients with ITP, who most of the time are Rh positive, our patients are Rh negative, so we don't worry about hemolysis at all in those cases. If you had a very large bleed, let's say like the patient I talked about had 180 cc fetal bleed, there is a chance for hemolysis, and in that case we would have to hydrate the patient, make sure she's doing okay with her kidneys. But because our patients are Rh negative, we don't deal with that very much. Your point's a valid point. If you used rhesus immune globulin to neutralize an Rh positive unit that was incorrectly transfused to the patient, I think it would be more of a potential, but we don't see that because our patients are Rh negative.
Thank you.
A question, are they developing a free DNA test for Cal? Will that become available soon?
So the question is there a free DNA test for Cal? One of the corporations in the U.S., at least until about 2 weeks ago, had the sole patent on all free DNA testing, and the problem is there's not a lot of money in Cal testing. Cal testing is available at Bristol in England, I know, and several other European countries, so it's easy to do. You need a little more DNA because there's only a 1 amino acid change between the K1 antigen and the K2 antigen, but it is available in Europe. It's not available in the U.S. Again, the only test in the U.S. right now available is free DNA for RHD.
Okay, great.
But I think it's coming down the pike.
Great.
Again, thank you so much for having me.
Thank you.